Okay, so welcome everybody and good afternoon. Thank you for attending this webinar on primary mitochondrial myopathies organized by EURO-NMD in partnership with European Academy of Neurology and EURO-NMD for rare neurological diseases. I wish to start by thanking our today's speaker, Professor Michelangelo Mancuso, for taking the time to share his knowledge with us. So Professor Michelangelo Mancuso is neurologist at the Neurological Clinical of Cesena Hospital and Associate Professor of Neurology at the University of Pisa. Scientific and research activity of Professor Michelangelo Mancuso has mainly been conducted in the field of mitochondrial neurogenetics and neurodegenerative diseases and stroke. Michelangelo is the coordinator of the neurogenetics group of the Italian Society of Neurology, co-chair of the neurogenetics panel of the European Academy of Neurology, and co-chair of the mitochondrial working group of the EURO-NMD. So Professor Michelangelo Mancuso will participate live in the Q&A at the end of the webinar. So don't hesitate to write your question in the chat box. And we kindly remind you that the webinar is recorded and will be available on our YouTube page. So thank you again to you all, and Michelangelo, the floor is totally yours.
Okay, thank you very much, Elizabeth, and thank you very much to all the people who are online with me today. And basically what I'm going to cover today is the topic on primary mitochondrial myopathies. And I will do my best to save enough time at the end to answer live to your questions, or if you want, you can just put down your questions in the chat, and then I will take them at the end of my lecture and try to respond to all of them. So let me start with a clinical case. This is a 42-year Italian woman who came to our attention for a 2-year history of progressive eyelid ptosis, ophthalmoparesis, dysphagia, exercise intolerance, and myalgia. This woman, basically there was nothing special in her past medical history. She only suffered of anxiety disorders. Her patients are not consanguineous, and she came to our first control with the previous CK level slightly increased, but almost normal. The neurological examination of this woman showed mild proximal weakness of the lower and upper limbs, mild proximal muscle atrophy, weakness of the facial muscles, ophthalmoparesis and bilateral aliptosis. Deep tendon reflexes were absent, no sensitive signs or symptoms, and no ataxia or other signs suggestive of the CNS involvement. So the patient blood test was absolutely normal, including the routine, the CK, the antibodies for acetylcholine receptor anti-mass. Thyroid function was normal, and the same was for vitamin B and E in her blood. The patient was evaluated, including the brain MRI, which was normal. The echocardiography was normal. The same was true for the EKG. We did the nerve conduction studies and the EMG, and the nerve conduction studies were completely normal, and the EMG showed mild myopathic changes in our patient. So basically, this is a female sporadic case of 42 years with ptosis, ophthalmoparesis, muscle weakness, dysphagia since her 40s. No signs of clinical or MRI involvement of the brain. Nerve conduction studies were normal, and the same was true for the blood test. So basically, once we have a patient like this, what should we do? The first question, what clinical features will help us leading a diagnosis? What are the different diagnoses we should consider in this case? Should we request a further diagnostic test? And in that case, if we decide to move on, which ones? And at the end, what's your final diagnosis? So the clinical features that can really help us in the diagnostic flowchart, are for sure the fact that this patient has a lot of muscular signs, including the ptosis, the progressive ophthalmoparesis, the limb girdle weakness, the absence of the deep tendon reflexes, and at the same time, no other symptoms or signs suggestive of other organs or other part of the central nervous system. So the differential diagnosis most likely, where else to go? Sorry, I have problems with my computer. So basically, we should, I guess, focus our attention in neuromuscular diseases. We should hypothesize neuropathy or a neuromuscular junction problem or a primary muscular disease. So do we have a polyradicular neuropathy here? Well, most likely, I don't think so, because we don't have any symptoms or signs suggesting of sensitive involvement. We have actually proximal muscular atrophy, which is not very common in polyradicular neuropathy. We don't have any sensory ataxia, so I would say this is not a polyradicular neuropathy. Can we think that our patient is affected by a neuromuscular junction disease? Well, here, what I can say that we didn't observe any diurnal variation in the severity of the symptomatology. We have no history of acute exacerbation or transient remission. We do have atrophy, and again, the antibodies which are usually linked to myasthenia gravis were negative. So I don't see a neuromuscular junction problem here. So basically, considering again the clinical phenotype, I would say this patient is affected by a primary muscular disease. So in order now to characterize the patient, what should we do after the first clinic evaluation? Should we move forward? I would say yes. Please consider again that this is a sporadic case, a female with normal CK values. So what should we do here? First of all, what we did, at least in our clinic, was to go through the forearm ischemic test, and what we found was an abnormal increment of lactate in our patient. Lactate was slightly elevated at rest, but during the exercise and after the exercise, the red curve is our patient was above the normal values. So most likely here we have a muscular disease with impairment of mitochondrial metabolism. So what should we do at this point? Should we do the muscle biopsy, or should we go directly to the DNA sequencing? So now things are quite different, but this patient is an historical case. I think we started studying this patient almost 10 years ago, so the panels were not routine at that time. So we did a muscle biopsy here, and what we observed was COX negative fibers. You can see here several fibers were not reactive at the cytochrome C oxidase staining. Here on the right, we have ragged blue fibers under the C with this proliferation of mitochondria in several fibers. And you also observe a variation in the diameter of many fibers, and we don't have any infiltration, no inflammatory pattern was observed. So we went through the DNA testing. This is the log PCR of our patient, where we found multiple deletion of the mitochondrial DNA. Sequencing the mitochondrial DNA, we didn't find any abnormal variant, but studying the nuclear genes, we found a compound heterozygous mutation in this gene, DGUK, which is at the end the cause of the disease of our patient. So we have a primary mitochondrial myopathy patient caused by a DGUK compound heterozygous mutation. This was just to introduce the topic of today, the primary mitochondrial myopathies, and we define primary mitochondrial myopathies, all these genetically defined disorders leading to defects in the oxidative phosphorylation system of the mitochondria, affecting predominantly but not exclusively the skeletal muscle. This was for the first time organized as a topic in an international consensus that was organized in Rome 6 years ago. Mitochondrial myopathy is an historical disease. The first mutation was described in the mitochondrial DNA in 1988, and where Anita Harding and Morgan Hughes will all described the lesion, like in our patient, of muscle mitochondrial DNA in patients with the mitochondrial myopathies. How do we recognize this entity? What's the clinical presentation? Here you have an overview. Patient with primary mitochondrial myopathy usually present fatigue, defined as important sense of hardness, lack of energy, and feeling of exhaustion. Very common, as in other metabolic myopathies, is also the exercise intolerance, the pain and the myalgia, which can be importantly exacerbated by the exercise. We have weakness, but also muscle wasting is possible to have during the disease course. We may also have, like in our patient, dysphagia. Spasms are not very common, but they can be present. And then another important point is the myoglobinuria, which is also another common situation we have in other metabolic myopathies. And this myoglobinuria, which is usually triggered by the exercise, is an important problem in these patients because it may lead to renal failure, as you know. But probably the most famous presentation of primary mitochondrial myopathy are, as in our patient, also the involvement of the eyes with ptosis and the ophthalmoparesis. This is just to give you an idea, an overview of the most relevant signs that we observe in the Italian population, in our Italian cohort. And you can see that considering the 20 more common signs in mitochondrial disease, you see that ptosis, ophthalmoparesis are present in almost 50% of patients with mitochondrial disease. The same is true for muscle weakness. Exercise intolerance is again very common in the entire mitochondrial disease cohort in Italy. Muscle wasting, swallow impairment, again muscle pain in 10% of the entire cohort, and so on. And these numbers here are not, of course, specific of patients with the primary mitochondrial myopathy, because as you are aware, I hope, and that this is the third webinar of mitochondrial disease we have organized. Most of the time, mitochondrial diseases are multi-system disease, so you may have skeletal muscle involvement plus other tissues involvement. When we talk about primary mitochondrial myopathy, we deal only with patients that are predominantly affected in their skeletal muscle. So if you take the entire mitochondrial disease cohort, the numbers of skeletal muscle involvement are not 100%, but if we consider only the patients with primary mitochondrial myopathy, all these numbers, of course, are much more representative. Regarding the PMM phenotypes, we can say that we have 3 different modalities of presentation of the primary mitochondrial myopathy. We may have a pure PO, progressive external ophthalmoplegia. We may have patients with mitochondrial myopathy without PO, or we can also have patients with this PO plus limb-girdle mitochondrial myopathy. So progressive external ophthalmoplegia is for sure the commonest phenotype of PMM, observed in almost 60% of the cases. We have bilateral aliptosis. Often this ptosis is the presenting symptom in the disease, associated most of the time with the compensatory frontalis muscle contraction, and in severe cases, tilting of the head. Ptosis is frequently associated with a slowly progressive, usually symmetrical limitation of the movement of the eye, the ophthalmoparesis, which at the end of the disease may become a complete ophthalmoplegia, and this is typically observed in all directions of the gaze. Diplopia sometimes is reported by our patients, but most of the time diplopia is not a complaint, which is completely different, for instance, from myasthenia gravis, where diplopia is very commonly observed in our patients. Intrinsic ocular muscles are not involved in the PMM. As I told you, PO, it can be a pure PO, but frequently is also associated with other signs of skeletal muscle involvement, and so we call it PO plus mitochondrial myopathy. Typically, what we observe is a slow progressive axial and proximal limb weakness, which usually affect predominantly the hip and the shoulder muscles. And most of the time, we also have, during the disease course, muscle wasting here. Muscle weakness may also cause difficulty of the swallowing, so we have dysphagia in our patients, and we may also observe respiratory failure during the disease course. Distal muscle weakness is very rarely observed in PMM. So this is another red flag. Usually mitochondrial myopathy is not a distal myopathy, and this may help us in the differential diagnosis when we have patients with distal muscle weakness. Most of the time, these are not mitochondrial patients. As I've said before, as in other metabolic myopathies, very commonly we observe fatigue, exercise intolerance, pain, and myalgia. Vice versa, as I told you, spasms is very rarely present. The same is true with myoglobinuria, which is an important problem that this patient may face after exercise. And most of the time, patients with myoglobinuria are either affected by cytochrome B mutation, or they may also have coenzyme Q10 deficiency. So this is the phenotype. So we have a clinical entity which may be restricted to the eyes, and we have pure PO. We may have pure mitochondrial myopathy without involvement of the eyes, or we can also have mitochondrial myopathy at the limb girdle plus the CPO, so broad spectrum, phenotypic spectrum. Regarding the genetics, here is extremely complicated, the scenario, because as you know from the previous webinars, mitochondrial disease are unique because they are genetically caused by either mutation in the mitochondrial DNA or by mutation in one of the hundreds of genes encoded into the nucleus, which are producing proteins that are transferred into the mitochondria and are therefore necessary for the respiratory chain machinery, for all the other metabolic activities we have into the mitochondria. Therefore, what we observe in terms of genetics, we may have PMM sporadic, which are never inherited, and this is the case of a mitochondrial DNA single deletion. So we may have a deletion of a single fragment of the mitochondrial DNA, the so-called common deletion is the most common situation where we lose around 5,000 base pair in the mitochondrial DNA. This is a sporadic genetic disease, means that if you are affected by a single deletion, you will not transfer the genetic defect to your offspring. At the same time, we can also have maternally inherited mitochondrial myopathies, where we have point mutation in the mitochondrial DNA. I will go back to this later. And we may also have PMM caused by nuclear DNA mutation, so Mendelian inheritance, which can be autosomal dominant or autosomal recessive. So it's an extremely complicated scenario that we have to be able to analyze once we have the suspect of a patient with the PMM. So regarding the mitochondrial DNA point mutations, so far we have more than 100 different mutations in the mitochondrial tRNAs that are associated with myopathy. Two of the most common point mutations in terms of prevalence worldwide are the so-called common mutation MILAS, the 3243 mutation in the tRNA leucine gene, or the so-called MERV mutation, the 8344A2G mutation in the tRNA of lysine. So most of the time, this mutation may cause extremely severe multi-system disease like the MILAS, like the MERV. Other time, this mutation may cause pure mitochondrial myopathy. Other times, they may cause myopathy plus some other organ failure, for instance, the heart involvement or the diabetes or the sensory neural hearing loss and so on. So it's extremely complex, and the cause of this wide variability of presentation of the same mutation so far is not completely understood. We know that we may have different mitotic segregation of our variant in different tissues. We also know that we have the threshold effect, meaning that we may manifest a symptom, a sign, only when we have a certain amount of mitochondrial DNA point mutation in that tissue, in that cell, below a certain amount, the tissue may compensate the mitochondrial DNA mutation because the heteroplasmy is very low. But again, even if we take two different patients with the same heteroplasmy in the skeletal muscle, one patient may have a pure PMM and another patient may have the MILAS phenotype with the stroke-like episodes. So the threshold effects, the mitotic segregation, and the heteroplasmy levels do not explain entirely the complexity of this phenomenon. And this is one of the most fascinating area of research in mitochondrial medicine, why the same mutation can cause so different phenotypes. As you can imagine, this is very important in terms also of genetic counseling, in terms of prediction of the evolution of the phenotype, and so on. So the tRNA mutation are commonly associated with PMM. When we talk about mitochondrial DNA protein coding genes, here we have around 20 different mutations, specific genes of the mitochondrial DNA, which are linked to the PMM. The most important one probably is the cytochrome B deficiency. So we have mutation in this subunit of complex 3, which can cause classical metabolic myopathy, clinically characterized by exercise intolerance, myalgias, and myoglobin. So when we move to the nucleus, so when we discuss about PMM caused by nuclear genes, here the situation is even more complicated because so far we have discovered at least 25 genes that are able to cause PMM and PO, genes that are encoded into the nucleus, and they may cause PMM in a dominant or in a recessive way. And most of the time, when we have mutation in these genes, the most common ones are in this table here. What we observe is a secondary imbalance of the mitochondrial DNA, which will present multiple deletions and also depletion. The amount of the mitochondrial DNA in the muscular tissue is reduced. So we can have autosomal dominant PMM, autosomal recessive PMM. The most common genes that we observe in our population, at least in the adults, are again listed in this table. And just to give you an idea of the complexity of the genotype phenotype we observe in patients with the CPEO. Here was a study from the Italian network that we coordinate. This was published 2017. And what we did was observing basically patients with discriminating patient with ocular myopathy, so patient with the CPEO. And we were comparing the genotype of these patients with the other patients collected in the Italian registry without ocular myopathy. So we were analyzing around 700 patients in Italy, and what we observed is that the most common genetic defect associated with the PO is the single deletion and Pol G, meaning that most of the patients with the CPO in Italy are harboring either a single deletion, so sporadic cases, or are affected by Pol G mutation. Vice versa, other genes like the common mutation 3243 Milas mutation, or the gene OPA1, or the MERV mutation, the 8344 of the NARP mutation, 8993, usually are not strongly associated with the CPO. This is an important observation because depending on the clinical manifestation, you may expect to find that a certain gene with a certain kind of mutation, and vice versa, knowing that I have a mutation in a specific gene, I may hypothesize that this patient may develop or not ptosis and ophthalmoplegia. But again, the important message is that we are talking about rare disease. And when we talk about rare disease, we should also keep in mind that, for instance, the CPEO is not always a mitochondrial disease. CPEO is not always a pure mitochondrial myopathy. We may, in fact, observe patients with PEO and brain MRI abnormalities. This is one of the reasons why our patient was doing the MRI of the brain. You could have said why you perform the MRI of the brain in a patient with a pure muscular phenotype, because sometimes we have patients with mitochondrial disease, which at the beginning of their history, these patients look as a pure myopathic patient, but in fact, they also have brain involvement. This is the case of the Kearns-Sayre syndrome, for instance, or of the Mingi, another ultra-rare mitochondrial disease. But also, please keep always in mind that if you have a patient with CPO and brain involvement, you may also have acquired conditions like the Wernicke encephalopathy, thiamine deficiency. So not all strange patients are mitochondrial patients. So we should always keep in mind that we have to go through a diagnostic flowchart, and we should, at the beginning, hypothesize more common situation. Then if we don't find a common situation, if we don't find specific biomarkers of more common condition, we should hypothesize a rare disease, a mitochondrial disease, mitochondrial myopathy. This is, for instance, what we have in the Kearns-Sayre syndrome. In the Kearns-Sayre syndrome, most of the patients, well, for instance, this was a study published a few years ago in Italy, where we were studying the biggest cohort in terms of numbers of Kearns-Sayre spectrum patients at that time known. And ptosis ophthalmoplegia plus myopathy, of course, can be an expression of a pure mitochondrial myopathy, but we may also have ptosis and ophthalmoparesis due to a single mitochondrial DNA single deletion, but they can also be affected by other organ or other CNS dysfunction, like the ataxia, like cognitive impairment, like tremor. In this case, the CPEO is a manifestation of a broader disease, which is the Kearns-Sayre syndrome, which leads to more severely affected not only skeletal muscle, but also brain involvement, premature death, and so on. So most of the time, the pure mitochondrial myopathy is a disease of the adult, but we also have primary mitochondrial myopathy with onset, with infantile or juvenile onset. How it appears, usually we have a floppy infant with hypotonia and the respiratory failure. In this floppy infant, the deep tendon reflexes are always reduced or absent. And then one of the most important myopathic form of infantile primary mitochondrial myopathy is the one due to the TK2 deficiency, mutations in the gene TK2. TK2 is an important gene that we are now discovering more and more often, screening the babies and also the juvenile, the kids at the teenagers age, because it can cause devastating infantile myopathy with death or respiratory failure within 1 year of the disease onset. But we also have TK2 patients that present a clinical phenotype that may mimic spinal muscle atrophy type 3. So we have a childhood onset between 1 and 12 years of age, but we also now observe patients with TK2 mutation at onset after the age of 12 years, but we also have patients with TK2 mutation and onset after the 20, the 25 years of age. One of the common markers of the TK2 pathology is the fact that if we study the mitochondrial DNA in the skeletal muscle, we always observe both multiple deletions and mitochondrial DNA depletion in the muscle. And another important nuclear cause of pure PMM is the so-called primary coenzyme Q10 deficiency. As you know, coenzyme Q10 is an important coenzyme that helps the electron transfer in the respiratory chain into the mitochondrion. We produce CoQ10 through a complex CoQ10 biosynthesis pathway. So we have different genes involved in CoQ10 synthesis. Therefore, we have different CoQ10 deficiency syndromes caused by different genes. When we have a CoQ10 deficiency, we may have at least 5 different phenotypes. Most of the time, these are children. But again, here we may also have onset at the juvenile or adult onset, especially the myopathic form of CoQ10 deficiency may begin at juvenile or adult onset. And this particular mitochondrial PMM is important to recognize because we can partially treat this patient with high dose of CoQ10 supplementation. So this is the overview. How can we, at this point, go through the diagnostic approach of a patient with possible PMN? So a family history is extremely important. Our patient was a sporadic patient. If we have a single deletion, the family history is negative, but in all other cases, you may have either matrilinear transmission of the disease or Mendelian transmission of the disease. And when we talk about mitochondrial disease, the family history must be taken meticulously with special attention to all these minimal, apparently unspecific signs that usually we are not very good in collecting daily practice, including, for instance, the short stature. Most of the patients with mitochondrial disease are short. The clinical recurrence of migraine in the family, all the exercise intolerance, the fatigue, the fibromyalgia phenotypes that frequently are described in the pedigree of our patients. Many patients with mitochondrial myopathy for years are followed as either psychosomatic patients or affected by chronic fatigue syndrome or fibromyalgia. So we have to really take all the single clinical symptoms and signs in the pedigree. Of course, we have to put special attention to the classical mitochondrial red flags when we have a patient with not only a mitochondrial myopathy, but a multi-system disease. And in general, a patient with ptosis, ophthalmoparesis, weakness, muscle wasting, and reduced or deep tendon reflexes, this is a very suggestive myopathic patient of probable or possible mitochondrial origin. We should always keep in mind that heart and mitochondria are extremely linked. Heart is very commonly impaired in patients with mitochondrial disease. We may have hypertrophic cardiomyopathy. We may observe dilated cardiomyopathy. Frequently, we observe arrhythmias and conduction defects in patients with mitochondrial disease. So when we do the diagnosis of mitochondrial disease, we should always screen the heart, even if the clinical history from the heart side is mute. So once we have the clinical suspect, of course, we do first the most simple test, which are the CPK. Usually CPK in mitochondrial myopathy is normal. The only exception is the myopathic form of mitochondrial DNA deficiency, the one caused by TK2. When we have a mutation in TK2, most of our patients present an increment of CK. Lactate is a very good biomarker. Most of the time it's normal at rest, but it can be mildly increased at rest, and especially during the exercise, it can raise abnormal. We have two very interesting biomarkers that are not implemented routinely in the clinical practice, but FGF21 and GDF15 in blood are almost constantly elevated in mitochondrial disease patients. They are not specific for mitochondrial disease etiology, but are very sensitive. Of course, muscle biopsy, we still need muscle biopsy, and we observe the classical mitochondrial hallmark, rather red fibers, these fibers here on the top, or the COX negative fibers, or the SDH positive fibers that you can observe at the combined staining with COX and SDH. The fibers who are COX negative remains in blue because the cytochrome C oxidase activity is quite zero in this. And these are classical histological figures of a patient with mitochondrial myopathy. And then, of course, now with the new generation, with the new NGS techniques, with all the power of the genetics, it's much easier to now find the mutation also directly in the blood. But we should consider that sometimes, like in the mitochondrial DNA single deletion, the only tissue affected may be the muscle. So we still need muscle biopsy to extract the mitochondrial DNA from the muscle in selected cases. So we have a lot of real life challenges in this disorder because we don't really know the natural history of PMM. We still are not very confident on which are the most reliable biomarkers and outcome measures for this PMM. We don't know how frequently we have to monitor the PMM patient over time to catch a clinical significant change, mainly in view of clinical trials that are coming. So we still have a lot of challenges. We are studying a lot PMMs in Europe and in Italy as well. This is, for instance, our recent study that was published on Neurological Genetics a couple of years ago. We have investigated 118 patients from Italy with either mitochondrial DNA point mutation or a nuclear DNA mutation or single deletion. You see here the mean age is around 50 and the disease duration is around 20 years. Both sexes are almost equally represented. And we have obtained a lot of interesting data. I don't have time to go through all of these, but these are very important data because we start having an idea on the correlation between genotype and phenotype in PMM, and we are now collecting more information to better understand the evolution, monitoring this patient every 6 months over time to see how these outcome measures may change over time. I have to go because I'm a little bit late. So what about the management? We have several recommendations published in the literature that you can consult. A couple of them came from the Mitochondrial Medicine Society. I have also published a NORD guide on primary mitochondrial myopathy on the NORD rare disease website. We also have several recommendation papers as a consensus-based statement that were published in the past few years. One is mainly focused on the management of the stroke-like episodes. This one on the diagnosis of MELAS, so these are not strictly linked to PMM. In terms of therapy, what we can do so far, the current treatment approaches are largely supportive and mainly includes vitamins and cofactors supplementation. We use coenzyme Q10, we may use debenone and other vitamins as cofactors. In few patients, like the ones with the coenzyme Q10 deficiency, we may improve the phenotype taking a lot of CoQ10 per os, and now we are start treating with nucleoside the patient with TK2 mutation. So CoQ10, we use a lot the CoQ10 as a suggestion is better to use ubiquinol, the reduced form of CoQ10, which is has a better action in the respiratory chain compared to ubiquinol. Not all the CoQ10 we can buy in the drugstore are the same. They have a completely different bioavailability. So the bioavailability of the CoQ10 really depends on the amount of oil in the formulation, as well as the delivery system. For instance, the powder CoQ10 is not absorbed almost at all. So it's important to take the right CoQ10 formulation. We may also use idebenone, which is very good in activating complex 1. The exercise, the role of the exercise in the PMM is still very important because by inducing with the aerobic exercise and resistant training, we may induce mitochondriogenesis. We can help the impaired mitochondria into the skeletal muscle to improve, inducing mitochondrial biogenesis. So we recommend the combination of progressive resistance exercise in patients with PMM, even though this has to be carefully monitored, because don't forget the risk of myoglobinuria if they do exercise too much. This is another paper that I don't have time to mention, but this is an important consensus that was published a few years ago, because there is always this legendary approach that in mitochondrial disease patient, a lot of classical drugs are very toxic for the mitochondrion, and there was a lot of confusion, which is a safe drug, which is a toxic drug. So if you are interested, you can take a look at this, study that was published a couple of years ago. Very briefly, the clinical trials. Now we have an explosion of clinical trials in mitochondrial disease. This is how clinical trials are growing in PubMed in the past 10 years. We have so far in the clinical trials more than 100 studies recruiting, and of those 65 are interventional. You can see here how these interventional studies are spread everywhere in the world, and most of the studies are either in Europe or in the US. Unfortunately, time is running. I don't want to go through details for the clinical trials, but this gives you an overview of how the mitochondrial machinery is complex, and we may act at different levels. So far, what we do, we try to provide vitamins and cofactors, but the future is in different directions, of course. We have to improve mitochondrial biogenesis, for instance, and this may be performed at multiple levels. If we induce mitochondrial biogenesis, if we improve the viability of NAD+, if we induce the synthesis of several nuclear genes inducing mitochondrial biogenesis, we may improve mitochondrial function. And we are developing a lot of studies in this field, and one of the most promising study is the use of niacin. And niacin is a precursor of vitamin D3, which was already tested in patients with mitochondrial myopathy, and we observe a lot of biochemical positive change, including an improvement of NAD+, an improvement of mitochondrial mass and OXPHOS function, but also we have an improvement in the exercise performance of our patients. We are now testing another molecule, which is a para-agonist. We have a phase 2b study running in Europe as recruiting patients with mitochondrial DNA PMM. Very soon, we will have another molecule ready for a phase 2b clinical trial, another molecule which not only increase NAD+ availability into the mitochondrion, but also improve the ATP synthesis and reduce ROS levels into the mitochondria. We have other molecules which act against the oxidative stress, like this molecule H176, now called sondicramol, which is under investigation in phase 3 trials. We may provide nucleoside supplementation, like in TK2 mutation that I was mentioning before. If we have a mutation in this gene TK2, we cannot produce the nucleotide to have the mitochondrial DNA. So what we can do, we can provide not because the enzyme is mutated, we cannot restore the enzyme so far, but we can provide a nucleoside to our patient to overcome this barrier. And these children were already published the first 16 TK2 cases, and now the clinical trial worldwide is ready to start. And another interesting approach is to stabilize the internal matrix membrane of the mitochondrial DNA of the mitochondrion, so we can stabilize the phospholipid with a molecule which is called elamipretide. It's another interesting molecule. I don't have too much time to go through this, but we already had phase 1 and 2 clinical trials, and the phase 2b trial was a little bit disappointing. I don't have more now time, sorry. But we will perform after the summer a phase 3 trial again with this molecule at a higher dosage of elamipretide. The last message is on the gene editing. We are not ready to do gene editing in vivo in humans, but we have nice animal models that can be now treated with gene editing, and we can transfer into the cells, but also in animals models, specific either restriction enzymes or nuclease that can eliminate the pathological variant in the mitochondrial DNA and try to restore the wild type mitochondrial DNA. So this is basically my overview for today. I want to thank all the different associations that are supporting our work. Of course, the European Reference Network of both neuromuscular and rare neurological disease, and the European Academy of Neurology. And if you really love mitochondrial medicine, here is a recent book that I have edited with Thomas Klopstock from Munich that provides a comprehensive update in mitochondrial medicine. So thank you very much. Antonio, I think that's it for me for today.
Thank you very much, Michelangelo. It was a very nice, very clear talk about primary mitochondrial myopathies, and I see that at the moment there is no one putting questions. I hope that will reverse. Usually it does, and so to break the ice, I will do one or two questions. So the first, the questions are obviously destined to make your life as miserable as possible. So I apologize. So the first thing is, do we have really primary mitochondrial myopathies, or do we have mitochondrial diseases with predominant myopathic phenotypes?
We do. The problem with mitochondrial disease in general is that because the mitochondrion is everywhere. So theoretically, if you have a mutation in mitochondrial DNA, all the tissue may be affected. So it's very difficult to have a pure mitochondrial myopathy, but the predominant myopathic phenotype is common. For instance, in Italy, we have at least 120 patients so far followed by us. So it exists. It must be recognized.
The other thing has to do with the phenotypical variability. It's not exclusive of mitochondrial disorders, as you know. I'm working with Giselle Bon, and in laminopathies, we have that as well. So what I know that when people ask usually what are the reasons why the same variant give rise to different phenotypes, people start talking about epigenetics, which is a kind of global
easy
explanation. So my question to you is, do you think that in mitochondrial disorders, there are candidates for epigenetic factors that should be probably investigated across different conditions or different phenotypes to see how they behave and how they can help to act as kind of biomarkers of evolution?
Yes, for sure, we have epigenetics, but not only epigenetics here, but also nuclear factors modulating the phenotype. We know for sure that if we take the common mutation, the 3243, we know that we have a specific genetic background into the nucleus, which modifies the clinical phenotype. So we have both probably nuclear DNA SNPs in different genes and epigenetic factors that should be investigated and they should be involved in the clinical variability. This is one of the major research area that is under development these years.
Michael Blash, you have a question. I have unmuted you, so you can unmute yourself and speak if you want.
Thank you. So I was just wondering, to make it clear, if you administer the coenzyme Q10 to everyone with mitochondrial myopathy, or just the ones with the primary primary coenzyme Q deficiency, and also if so, are there different doses, like higher for the primary deficiency, or yeah?
Okay, thank you for your question. So primary coenzyme Q10 deficiency is extremely rare. So unfortunately, I would say, because it's one of the few that could be treated better. So most of the time, you don't have a patient with CoQ10 deficiency, at least primary CoQ10 deficiency. We frequently have a secondary CoQ10 deficiency in our patients with the PMN, but that's a different story. So we do treat patients with PMM in general with coenzyme Q10, even though the rationale is quite weak. And there are no clinical trials performed in the past supporting the use of CoQ10. But in several patients, amount ranging, let's say, from 200 to 500 per day provide benefit in the clinical symptomatology. But please be aware that this is not a real treatment. It's a supplementation that may help our patients, but we don't have any randomized clinical trials supporting this approach. In fact, I know that in several European countries, but also in the US, there are countries where it's not reimbursed, the CoQ10 at the patients, and there are centers that don't use CoQ10 at all. So it's quite a complicated area, but I do recommend CoQ10 to my patients.
Thank you very much.
Federica Montagnese, do you want to speak, please? You're unmuted.
Yes. Hi, Michelangelo. Thank you for your talk. I just have a practical question to you, because some of the red flags you've shown for mitochondrial myopathies are also sometimes unspecific. So, you know, the myalgia and exercise intolerance, we have lots of patients coming to our clinic with these unspecific symptoms, and they all are well aware that it might be a mitochondrial myopathy. So, you know, if the CK is slightly elevated to 200, 300 with the myalgia and exercise intolerance, this is a very common problem we have. So what is your practical approach? How cheap is your approach? Because we could offer muscle biopsy and genetic testing to all patients, but we need to narrow it down.
Yeah, thank you. So of course, if we don't have a patient with the CPO, because if you also have CPO, maybe it's right, plus metabolic symptoms or signs. So let's say your patient has no PO, therefore it's more complicated, and it can be a patient with any metabolic myopathy or even nothing. You know, that's also good. So what we should do is, as I was trying to say, but the time was not so much. First of all, the family history, because if the patient is a mitochondrial DNA inherited patient, you have matrilinear inheritance. If it's a nuclear DNA patient, you have Mendelian inheritance. Most of these patients have a family history of cramps, weakness, exercise intolerance, and whatever. This is also common with other metabolic diseases, of course, but it gives you at least one more hint to move forward to the diagnosis of a rare metabolic disease. Another very good test, which is cheap, is lactate, because it's true that normally at rest is specific, but ischemic exercise or also aerobic training exercise and so on, you can observe abnormal impairment. But at the end, for me, the most reliable new marker that we have, which is extremely cheap, is the GDF and the FGF21 and the GDF15. Unfortunately, this is not very well used in the clinical settings, but I can say that most of the patients with mitochondrial disease and mitochondrial myopathy have an increment of both. This, as I say, this is not pathognomonic. This is not a specific biomarker, but for sure it's very sensitive. So you can also have an increment of GDF15 after COVID infection, for instance. But in an appropriate clinical setting, you have this family history, you may have a pharmacoparesia or ptosis. You have mild increment of lactate, and of CK, FGF, and GDF15 may really help you a lot. If you don't have FGF and GDF15, really it can be a challenge. But now with the NGS technology, at least it's becoming cheaper to exclude metabolic myopathies. But I don't say there is an easy diagnostic trick.
Thanks.
Okay. Thank you, Michelangelo. It was, as you see, a very interesting and debated communication, and we hope to have you very soon, probably in September again. And I wish to thank you in name of the RN and of our participants today, and the ones that will meet us in the web, seeing your webinar through our website later. Okay, thank you. Bye-bye. See you.
Thank you very much, Michelangelo. Bye.
Thank you to everybody, to all the participants, especially. Thank you.
Bye.
Good day. Bye. Ciao.
Bye.